Hello NEET PG aspirants, welcome back to the PYQ series. I am again with a new video of this series, and this topic is very important: drug resistance tuberculosis and its management. You must have seen question has been asked every year, some or other question from tuberculosis, maybe from microbiology, maybe from pathology, maybe from medicine. So for that reason only, I have made this topic in such a way that it will not only include the microbiology content but also include the pharmacology and medicine content. So let's start with the video. So it is PYQ number 7, drug resistance TB and its management. So the MCQ which was asked: a 40-year-old patient was diagnosed with pulmonary tuberculosis. On testing, the strain of Mycobacterium tuberculosis was found to be resistant to rifampicin, isoniazid, streptomycin and gefloxacin. What type of TB is this? Multi-drug resistant TB, extensive drug resistance TB, pre-extensive drug resistance TB and polydrug resistance TB. So to answer this question, we need to know the various types of drug resistance TB and their definition, and for that we need to know first of all the drug required to treat TB. So WHO has given the classification of TB drugs in 2011, and in that classification they have classified the drug into 5 groups: group 1, group 2, group 3, group 4 and group 5. And the group 1 is the first line oral anti-TB drugs, and it includes the popular anti-TB drugs that are isoniazid, rifampicin, ethambutol and parazinamide, HRZE. Okay. And the group 2 includes the injectable anti-TB drugs, also known as second line injectable drugs. Okay. And it includes the aminoglycosides, streptomycin, kanamycin, amikacin and capreomycin. The group 3 includes the fluoroquinolones. So it includes the levofloxacin, moxifloxacin, gatifloxacin and ofloxacin. So these 3 groups are more important to know to understand the definition of drug resistance TB. Okay. Apart from this, the group 4 includes the oral bacteriostatic second line anti-TB drugs, and it includes ethionamide, prothionamide, cycloserine, teridazolone and paraminosalicylate acid. And then group 5, which includes anti-TB drugs, and at the time when the classification was given, there was no data was available for the long-term safety and the efficacy of the drug, so they were included in group 5. However, the agent which is mentioned in group 5 are now the part of drug used for treatment of MDR-TB. So I will discuss that also, don't worry. So this group 4 and group 5 is now used for treatment of what? MDR-TB. So group 1, 2 and 3 is used for treatment of DSTB, that is drug sensitive TB. And group 4 and group 5 is now used for treatment of MDR-TB. Okay, so remember it like this. Okay, so now let's see the definition of various drug resistance TB. The first one is MDR-TB. What is MDR-TB? MDR-TB is called when there is resistance for both isoniazid and rifampicin. Okay. Pre-XDR is called, as per CDC, when there is resistance for both isoniazid and rifampicin, along with resistance with at least any one of the fluoroquinolones as that I mentioned before, or at least any one of the second line injectable drugs. So any one of these two definition is given as per CDC, but WHO says that resistance to isoniazid and rifampicin or only resistance to rifampicin along with resistance to any one of the fluoroquinolones. They don't include the resistance to second line injectable drug for the definition of drug resistance TB in either case of pre-XDR or XDR both. So this SLID is not included in the definition of WHO. Okay. This XDR TB is defined by CDC. Again, this MDR TB, that means resistance to both isoniazid and rifampicin. Okay. MDR-TB. Okay. MDR-TB along with resistance to both fluoroquinolones and SLID, at least any one of. But now this time both, that means both fluoroquinolones and SLID. Okay, in case of pre-XDR, either of these, either fluoroquinolone or SLID. But now when both are included, then it becomes XDR. So this is the only difference between pre-XDR and XDR. Okay. Or apart from this, in 2021, WHO has revised its classification, and in that classification, they included the resistance to bedaquiline and linezolid, which are the drug used for treatment of MDR-TB in the definition of XDR. So, apart from resistance to fluoroquinolone SLID, if it is resistant to fluoroquinolone and resistance to either of these two drug used for treatment of MDR-TB, that is bedaquiline and linezolid, then it will be considered as XDR-TB. WHO, as I told, that they don't include this first definition, that is, they don't include this SLID. So SLID is not included in WHO definition. So only this below two definition is included in WHO. Apart from that, WHO also said that even if it is only resistance to rifampicin, that will also be considered as equivalent to MDR-TB. Okay, but not the CDC. Okay, what is polydrug resistance? Resistance to more than one first line anti-TB drugs apart from H and R. Okay, that means resistance to either Z or either E apart from resistance to isoniazid and rifampicin. Monodrug resistance, that resistance to either of these, either H, either R, or either Z or either E. So any one of these four, if resistance, then it is called as monodrug resistance. Poly, that means H plus R and any other like that Z or E. Okay, so I hope this is clear. Just repeat this uh, content, and then you will be able to understand. It's not that difficult, but yeah, it is little confusing, so you have to keep on revising it. Okay, so make a note from this, and then I believe that you will be able to understand. Okay, so the treatment of this MDR or RRTB, there are two approaches given by WHO. The first one is longer MDR-TB regimen, and the second is shorter MDR-TB regimen. First, longer MDR-TB regimen, why it is called as longer? Because of the longer duration of treatment. That is, the treatment duration is around 18 to 20 months. Whereas the treatment in duration in case of shorter MDR-TB regimen, it is around 9 to 12 months. So it is almost double in case of longer MDR-TB regimen. And when longer MDR-TB regimen is recommended, when MDR or RTB is present, the strain is present with or presumed to have fluoroquinolone resistance. Okay, presumed to either presumed to have or confirmed fluoroquinolone resistance, then we will use longer MDR-TB regimen. Okay, or if the patient is suffering from severe pulmonary or extrapulmonary TB, or the patient is previously treated with second line drugs. Okay, so either of these three conditions, if it is there, then we will prefer the longer MDR-TB regimen. And what are the drugs used in longer MDR-TB regimen? So the drugs are classified into three groups: Group A, Group B, and Group C. The Group A includes the levofloxacin or moxifloxacin, bedaquiline, linezolid. Now you know this definition when I told you that the XDR definition included the Group A MDR-TB drug. So these are the Group A MDR-TB drug which was mentioned in the definition of XDR-TB. Okay, bedaquiline and linezolid. This Group B include clofazimine and cycloserine or teridazole. And this Group C includes ethambutol, delamanid, pyrazinamide, imipenem or meropenem, amikacin or streptomycin, ethionamide or prothionamide, and para-aminosalicylic acid. So these are three different groups of drug for used for longer MDR-TB regimen. Okay, so when to use and what drug we should use. So the regimen includes all Group A agents. That means we take either of these two, that is levo or moxi, then bedaquiline and linezolid. These three will be included. Okay, and any one of these two, Group B and any one of group B agent. Okay, so either clofazimine or cycloserine or terizidone. Okay, so when to use group C? Group C can replace either of these group A or group B if it cannot be used. Suppose if bedaquiline cannot be used, so it may be replaced with any of the group C. So how to choose that which group C should be included? So the criteria is to make fully oral dose regimen. Till the time we can make the oral dose regimen, fully oral regimen, we will include those drugs only from the group C. Okay. So that, because first of all it is the injectable are very inappropriate to use, and also we need supervision. So for that reason only we will include first the oral drugs. If that oral drug cannot be given, then only we will go for the parenteral drugs. Okay. So this is the longer MDR-TB regimen. Okay. Now the shorter MDR-TB regimen, it is recommended in cases of when there is no extensive pulmonary disease or severe extrapulmonary disease. So if it is severe or extensive, we will go for longer. If it is not there, we will go for shorter. If there is no history of exposure to one or more second line drugs used in shorter MDR-TB regimen. So those drugs which are used in shorter MDR-TB regimen, if the patient has got no history of exposure for more than 1 month, then we can give him or her the shorter MDR-TB regimen. And also there should be no resistance to the component drugs, that whatever the drugs included in the shorter MDR-TB regimen, there should be no resistance to those drugs. Okay, and also there is confirmed sensitivity to fluoroquinolones. So these are the criteria which is required for shorter MDR-TB regimen. Okay. And this shorter MDR-TB regimen has got two phases, initial phase and continuation phase. Initial phase is of 4 months, which may be extended to 6 months, and the drugs are bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, high dose of isoniazid, and ethionamide. So these are the drugs which are used in the initial phase. In the continuation phase, which is of 5 months, what we will do, we will not include this bedaquiline, high dose of isoniazid and ethionamide. Rest of the drug will continue for another 5 months. That is levofloxacin, clofazimine, pyrazinamide and ethambutol. Okay. So this 5 month is fixed. We cannot extend this duration, but yeah, this initial phase may be extended up to 6 months if the response is not very proper or it's slow. Okay. Now, what are the treatment for isoniazid monoresistance or a polydrug resistance in which rifampicin resistance is not detected? So, for that we can use this levofloxacin, rifampicin, ethambutol and pyrazinamide. And what is the duration? It should be used for 6 to 9 months. Okay. The duration for isoniazid monoresistant treatment is 6 to 9 months, and it should be done with levofloxacin, rifampicin, ethambutol and pyrazinamide. So levofloxacin, rifampicin, ethambutol and pyrazinamide. Now there are two more regimen. First is BPaL regimen, which is recommended for MDR-TB with additional fluoroquinolone resistance. Okay, and the duration is of 6 months. The duration of treatment is 6 months, and it includes the B stand for bedaquiline, PA stand for pretomanid, and L stand for linezolid. The bedaquiline, pretomanid and linezolid, these three drugs are included in this regimen, and this drug given under operational research condition does not apply to the routine programmatic use. So we will use only for it for research conditions. Okay, and then there is another regimen which is under trial, that is BPaMZ regimen. It includes bedaquiline, pretomanid, moxifloxacin and pyrazinamide, and it's tested to reduce the duration of treatment of MDR-TB and DS-TB to 6 months and 4 months respectively. Okay, that they want to reduce the duration of treatment for MDR-TB by changing the regimen, that is from that longer duration or shorter duration to bedaquiline, pretomanide and moxifloxacin and pyrazinamide. and reduce it to 6 months, and reduce this to drug sensitive to 4 months. Okay, so these are the treatment for drug resistance tuberculosis. Now, what are the genes responsible for drug resistance? So for isoniazid, the gene responsible are, the first is CATG and the second is INHA. This CATG codes for catalase peroxidase, okay, and which converts basically this isoniazid which exit in product form into active form, okay, biologically active form is converted because of this gene. So mutation in this gene will leads to development of resistance to isoniazid, and that is actually a high level resistance. Okay, that means even a higher dose of isoniazid cannot reverse this mutation. Isoniazid INHA regulatory region, it is basically a NAD dependent enoyl acyl carrier protein reductase codes for this, and this is with the primary target for isoniazid. So this is the primary target for isoniazid as well as the homologue, that is ethionamide and prothionamide. So what it will confer, it will confer low level resistance to isoniazid and resistance to ethionamide. Okay, so that low level resistance can be overcome by increasing the dose of isoniazid. Okay, now this rifampicin resistance occur by mutation in RPOB gene, and this RPOB gene codes for the beta subunit of RNA polymerase, which is target of rifampicin and leads to rifampicin resistance. And this fluoroquinolones resistance occur by mutation of this gyrase A and gyrase B, GYRA and GYRB gene, which codes for DNA gyrase. And what is this DNA gyrase? This DNA gyrase is actually the target site for fluoroquinolone, and it leads to levofloxacin resistance and low level moxifloxacin resistance. Okay, and then second line injectable drug, if you'll see, again two genes are responsible, RRS and EIS. This RRS codes for 16S rRNA, and amikacin and kanamycin binds to this 16S RNA to inhibit protein synthesis. Okay, so what it will lead to? It will lead to high level of amikacin and kanamycin resistance and low level of capreomycin resistance. And then EIS is basically enhanced extracellular survival gene of MTB, and mutation in this gene leads to enhanced production of enzyme, that is aminoglycoside acetyltransferase, and leads to inactivation of drug. And which drug is inactivated by this is kanamycin. So kanamycin is not affected, but amikacin and capreomycin may become effective. So EIS is responsible for kanamycin resistance. However, RRS is responsible for amikacin and kanamycin resistance, but not but a low level of capreomycin resistance. Okay, so this is the mechanism of drug resistance, or the gene responsible for drug resistance. So there are certain newer method apart from the conventional DST for detection of drug resistance. There are certain newer methods, and these are gene expert MTB RIF. This gene expert MTB RIF is basically a cartridge based nucleic acid amplification test, which is a closed system in which the PCR is performed after the extraction of the DNA from the bacteria, and it will detect both Mycobacterium tuberculosis complex and rifampicin resistance. So this is the advantage of this gene expert, that along with identifying the organism, detecting the organism, it can also identify the resistance to rifampicin in the strain. TrueNat MTB RIF is similar to gene expert. The difference is that it is chip based micro PCR test, and second thing, it is indigenous, that is, it is developed in India, and this also detects both MTB complex and rifampicin resistance. Okay, and then there is another method known as line probe assay, which is basically a DNA strip based test which uses PCR and reverse hybridization. Okay, so it uses PCR and reverse hybridization. So first of all, what we will do, we will extract the DNA, and this DNA will be amplified by PCR, and then the probe is hybridized to it, which leads to formation of colorimetric band, and thus the resistance is detected. So this line probe assay is of two types: first line probe assay and second line probe assay. What does it mean? That means this first line probe assay will detect resistance to the first line drug, that is Isoniazid and rifampicin, whereas the second line probe assay will detect resistance to the second line injectable drug and fluoroquinolones by detecting the genes which I have discussed earlier. So these are the various methods for detection of drug resistance. I told you about the drug used for treatment of TB, the definition of various drug resistance TB, the management of the drug resistant TB, and the gene responsible for drug resistance. So I hope the topic is now complete in all the aspect: pharmacology, medicine, microbiology, and I believe that with this video you will be able to answer any question related to drug resistant TB and its management. So all the best, and I will see you in the next video. Take care.